This is the Aware Families Podcast, the show that brings you a science-based, practical look at how to use the principles of functional medicine to keep your family healthy. All right, welcome back to the Aware Families Podcast. This is Lucky 13, episode 13.
I didn't even realize that.
Yeah.
That's awesome.
So I was born on Friday the 13th, so...
Oh, see, it's a special day.
So 13th is a different, it does have a good connotation.
It was actually my favorite number growing up. Mm-hmm. You know, when you have things like that, 13 was my favorite number. It's
been much maligned. I don't know why, but,
Awesome.
I'm taking 13 back.
Right, yeah.
But yeah, so it is summertime in the Valley.
Yep.
And things are rocking and rolling. I know you've been crazy busy, but also doing a lot of fun stuff.
Yep, fun stuff. Getting outside, being out in the fresh air.
Wake surfing.
Yep, wake surfing. My oldest tried wakeboarding last time, and he loved both. So he loves both.
Yeah,
very fun.
Yeah, mm-hmm. And it's also funny too because the water's like. It's not ice anymore, but
it's darn close.
Yeah, but it's a different thing when people come from like southern places and then they're like we're all doing all these water sports and people get in the water and they're like, what
how do you stay in here? Yeah, totally. And my oldest I think has a different temperature, sensor.
Yeah.
And so he's in there with no wetsuit. I am in there with a full wetsuit.
Yeah.
I'll tell you. So.
Yeah, and because we actually for the second time biked going to the Sun Road up in Glacier National Park, and so we did it right after Mother's Day, and went up there and did our annual kind of polar bear plunge into Lake McDonald, which if anybody's been to Glacier, it's the big lake kind of by Apgar, the base and the western part of Glacier National Park. And it's
freezing. Yeah,
and so it's basically the water that had literally just been, glacier or snow 5 minutes before.
Yep.
So right around Mother's Day, it was, high 30s, I think, maybe low 40s. Yeah. But one of those ones where you go in and you all of a sudden go into that, like, it's sort of like if you're me, a Wim Hof, that's like what you got to strive for. But, I lasted maybe 30 seconds in there.
That's actually really good.
And then my body's just like, get out.
Yeah.
And then we plunged again this past weekend.
It's warmer.
And it was warmer. Mm-hmm. I mean, it's still chilly,
warm.
But not the I'm going into some sort of shock type of chilly.
Yeah.
But, it's a kind of rite of passage. So.
Yep. I know. My oldest also jumped in Lake McDonald when he was a lot younger. In early May, right?
Yeah.
And it was one of those where we then fished him out because he was like,
your body kind of locks up.
Kind of stopped. Yeah, you could tell it was not what he was expecting.
Mm-hmm.
But
if you survive it,
yeah.
It's like, good for your mitochondria.
Yeah, yep.
That'll be a whole cold plunging will be a whole separate podcast.
Yeah.
We'll get into that later.
And it's natural up here.
Yes, exactly.
Yeah.
But today,
okay.
to diverge, we're going to talk about a little something different. We're going to talk about food reactions, was it something I ate? I think is like a sort of a good lead into that, sort of the whole, and this will be again an overview of just all the different types of potential adverse food reactions, which includes actual food, I guess technically defined food allergies versus sensitivities versus intolerances, and kind of talk about what the differences are. And kind of going through that.
Right, because there are significant differences when we're, speaking about food. And it's kind of interesting, too, because sometimes we relate everything to food, right? And other times we don't relate anything to food.
Yeah.
And it can be a very, very large culprit.
Yeah, it can be. And I think a lot of it gets missed in the kind of standard medical community because there's this common, I think, sort of misinterpretation or misunderstanding that either you have a classic like anaphylactic type of food allergy or there's no food reactions.
Right. And if we talk about anaphylaxis real fast, just to define it, right?
Yeah.
So you can go from being completely fine to all of a sudden potentially having breathing issues, but it can also be hives. You can have nausea, vomiting.
Yep.
Right. So there's other symptoms of anaphylaxis besides just, oh my gosh, I can't breathe. Which is just, I think, crucial to define there.
Yeah,
too.
and like the severity of it.
Yep.
And surprisingly, it's I think up to 5% of the population, at least in the U.S., has had an anaphylactic reaction at some point in their lives, which is like that's 1 out of 20 people. That's a lot of people.
Which is wild.
And increasing, of course.
Yeah.
We'll kind of go down that rabbit hole in a second.
Yeah.
But yeah, that part of it. But again, there are a whole other list, and you need to look no further than celiac disease, which is obviously a very medically recognized condition that is completely different immune type of reaction technically qualifies as like a food allergy, but doesn't show up on any of the other food allergy testing, but is a very definable disease disorder that's directly food related. And we'll talk about that a little bit later too. But yeah, there's a whole spectrum of food related adverse reactions that can get missed if you're just thinking of the lens of like either you have an anaphylactic reaction or nothing. Like totally not true. So don't get gaslit, you know.
Yeah, and that's, I think, one of the things we spend a lot of time talking about here at Functional Medicine Associates, right, is we talk a lot about food. You know, I know you do. We do a very thorough dietary history, right? One of the first things we do. But a lot of times, and I don't know if you recognize this with some of your visits, people don't always pull out food as a trigger, right? So even when we're coming into a functional medicine assessment, that might not be something that is like, oh, hey, I'm wondering about this, or I'm curious about
Especially if it's
this.
a not GI type of thing.
Right. Yeah. But even if it is GI, sometimes it's still not related.
True.
You know, internally, we're just like, oh, no, it's not eggs, right? Or whatever. Yeah.
Sometimes there's denial, like inside you know that it is, but you don't want it to be.
Well,
you know, like the gluten thing. People are like, no, it can't be. It can't be.
I know. And we'll talk a little bit about like those glutenomorphin reactions and caseomorphin reactions, you know, and how it makes you kind of crave the food that you probably shouldn't be having. Yeah. Anyway, so should we go back and kind of define our different groups that we're talking about for foods?
And just like, I guess to kind of preface this is like, this is also something that you or somebody you know very likely falls in one of these categories because they're so common. And all adverse food reactions are on the increase, including anaphylaxis and food allergies, but also eczema, eosinophilic GI disorders, or EOE, which we'll talk about.
And mast cell disease.
Mast cell disease. So even celiac is increasing.
Celiac, but mast cell activation syndrome, you know, it's starting to be more and more known. And again, I have quite a few patients with this. And so see this a lot in the clinic, but it's not in somebody's like top 3 differential diagnoses, right? And yet
it's sneaky.
It's sneaky, and it's, you know, multi-system. And so oftentimes we want to take this diagnosis to cover this and this diagnosis to cover this. So I think all of these kind of have that in common.
Yeah, food reactions can be, what is the word, pleomorphic? Is that where it just kind of can be like, you know, looks like a lot of different things.
Yeah. Oh, wait, this is your head. This is your skin. This is your GI system. Whoa, what? Yeah, totally.
And so just to briefly go down the rabbit hole, why do you think that all these things are increasing?
Oh, yeah. Well, that's a deep hole.
Dip your toe in.
I know. Okay, I think a lot of things. I think our food is different, right? I think we have a lot of extra pieces in our food now. We're not eating just the food that we grow, right? Or kill. We have environmental triggers. We have socioeconomic triggers, right? So stress and the fast-paced life, I really do think
that
contributes.
Leads to immune dysregulation.
Yep.
Yeah.
So, you know, everything that we talk about when we talk about our 6 pillars, I think contributes to an increase in food issues.
Yeah. And the all-important gut microbiome, huge in you know, preventing or potentially backtracking out of food reactions.
And again, you can lead that to stress, right? And so stress, when we talk about stress, who doesn't have stress?
Yeah.
You know, I'm talking about the stress. You and I were both discussing this just on the way in this morning, right? Like, oh, okay.
Yep.
We both have things going on, and it's like
a lot.
Yes. Yeah, a lot. So it's like, what are we doing? What are we all doing to help prepare so that we can, you know, prevent dysbiosis and microbiome issues? But
and going back to our was it last podcast before that, I talked about the first 1,000 days, and that whole, like, from conception through age 2 to 3 is a huge thing, and that's obviously when a lot of these food reactions start,
right?
And I guess I don't know what you want to call it, not improper, but sort of a suboptimal first 1,000 days for any host of reasons. All the things we talked about, like microbiome disruption, early antibiotics, toxic exposures in the food, things like that, that then lead to that, like, leaky gut and the immune dysregulation. Then the immune system freaks out against stuff that it shouldn't, namely foods, you know, in a bunch of different ways. And that can look like a lot of different things and present a lot of different ways. But all those things, I think, kind of lead into that. You know, we are not living in the environment we were, you know, a couple hundred years ago, or 100 years ago,
40 years ago,
or 40 years ago. Yeah, totally.
Yeah, it is way different for sure.
And so I kind of, you know, and I have a chapter in my book, the Feeding Our Children book, about this, because I wanted to dispel a lot of the myths and try to kind of break this down, and so people can start to see sort of the categories that these things sort of fall in, and realize that there's all these different lists. And so maybe having the nomenclature, having the sort of naming system a little bit more defined, so that, you know, if you do go to your practitioner or provider, then maybe it's a little bit easier to kind of get some of this stuff sifted through.
True.
And so the first thing is, it is an immune-mediated versus non-immune-mediated food reaction, meaning, is your immune system involved in some way, shape, or form, or is it some other reaction that doesn't involve your immune system? Which is
even, and you and I were speaking about this earlier, even a little controversial there, because we're looking at, you know, immune can be IgE or IgG, right? And so we're not going to go super deep into some of this, but just knowing that there's even some controversy surrounding immune reactions.
Yeah. So obviously immune system is like your white blood cells and all the antibodies and things that it makes. And there's different components of your immune system. And really briefly, there's like something called your B cells that make antibodies. And that's like your IgE, your sort of classic food allergies are what's called IgE mediated, meaning those type of antibodies are involved. You have these IgE molecules, these antibodies that are targeted to certain foods. If you have this food reaction, you eat that food, those antibodies are like, ooh, enemy, and the IgEs kind of stick on that food, and then it triggers your favorite cells.
The mast cells.
The mast cells. And the mast cells are other part of your immune system. And this is all like in certain responses, a normal, healthy part of your immune system. Like mast cells can kill parasites and all kinds of nasty critters.
Yeah, they're not bad. They just, when they're not functioning maybe properly.
When they spaz out.
Yes, when they're like, ooh, high alert, and we don't really need to be on high alert.
And then a little bit of histamine or targeted histamine, again, is you know, necessary for life. But what happens if you get that histamine dump?
Right.
Where all of a sudden you get the surge of histamine.
Yep, and then you have lots of symptoms.
Which is basically the anaphylactic reaction is largely, you know, which is why antihistamines like Benadryl and things like that are a key part of like that treatment of anaphylactic. And,
you know, we have to just hit that mast cell activation here, right? You know, also because antihistamines are one of the key treatment options of that too. And there's other ways to do it besides just your classic Zyrtec, Allegra, Pepcid.
Yeah, and mast cell stabilizers like quercetin or quercetin, however you want to say it. Vitamin C is a stabilizer.
I quercetin.
Yeah, chromalin is something we used to use. Yeah.
Actually, we still use it. We use it quite a bit.
Yeah. And so that's so that basically the IgE mediated, your classic allergies involve histamine. All right, and what are the classic food reactions that we see for IgE mediated?
Oh, like your hives? Is that what you're talking
about?
Yeah,
what foods are the most common triggers? Yeah.
Dairy.
Yeah,
so
dairy's
milk,
a big one.
Eggs,
classic.
Peanuts.
Yeah, peanuts and nuts. Yep.
Soy, corn. Wheat.
Yeah, corn is a little less, but still up there.
Oh, corn is maybe more like adult.
Adult and more like some of the not as severe. But yeah.
Sesame.
And the seeds are you know, I always forget about those, but there's people that have really severe reaction to the seeds, especially sesame seeds.
Right.
And then you said wheat, fish and shellfish.
And fish. Yep, shellfish. I always think shellfish, but other people do react to other fish too, not just the shellfish and the crustacean type, but that one is always kind of far back in my brain. The other thing with kids is for whatever reason, we see strawberries a lot.
Yeah. Which can be either oral allergy or hives.
And they'll get the big red, you know.
And the oral allergy is also part of this. It can be a lead-in to, you know, having a more anaphylactic, or it can be just the itchy mouth.
Describe the oral allergy real fast, because I see what you're doing, but maybe our listeners can't see what you're doing. So
it's usually, the first thing is like they get like a itchy, stingy kind of tongue feeling. And so usually with this, if it's purely the oral allergy syndrome, it just stays in the mouth and doesn't progress to anaphylaxis, although I think that can be early signs of like, oh, this food didn't react well.
Then their lips feel kind of funny, and they talk about a tongue fullness.
Yep, tongue fullness, itchy, kind of
scratchy
like
throat.
electrical kind of feeling, like zingy feeling in their mouth. Scratchy in the throat. And I think because there might be like some minor swallowing things, but usually not, your throat's not completely closing up with that.
Yeah.
And yeah, that like then you start looking at things like melons and berries are common.
So yeah, my husband with melons, he said that because he can't do melons because he gets the same symptoms.
Yeah.
But there can also be that cross reactivity with trees, right? And different plants. And
that's where like the latex allergy is
Yes.
also related in with a lot of this stuff too.
Yep,
So
I know, and that cross reactivity, and I know when you see the allergist, sometimes they're like, okay, so just so you know, you don't probably need to, you know, put a hole in your throat and stick a Camelback tube down there to breathe when you're out hiking, but maybe avoid it.
Yeah.
Yeah.
This is one thing. If there's either suspicion of this or you have, a true anaphylactic or significant food allergy, this is something you should be plugged in with an allergy, an allergist, allergy immunologist.
And they do a lot of, and we'll talk a little bit about all the types of testing here in a minute. But one nice thing with the allergist is, they can also start doing those like trials where they start desensitizing.
Yeah, and there's a lot of newer therapies. Like
so there's a
lot
of
microdosing of a different type.
But there's hope out there, I guess, is my point. So it's not like you have to be completely without.
And so, the anaphylactic, it's interesting, like up to almost half the kids who have like some IgE mediated food allergy will have an anaphylactic reaction at some point. We talked about how 5% of the general population has had an anaphylactic reaction to something. Sometimes you never figure out what it is, which is crazy.
Yeah, and people end up in the ER, and we'll see them here, and they're like, I really have not identified what the issue was.
And this is no joke. I mean, this is, I can't remember what the number of fatalities, but it can be fatal.
Yeah.
And
bee stings. I mean, so it's also not just,
Yep. Bee stings is a big one. So this is one. EpiPen, the epinephrine auto-injector pen is life-saving. You get, and you can't just be like, oh, we're treating with Benadryl, we're good to go, because there can be a delayed reaction where then it comes back.
Well, and even with the EpiPen, which is why we always give 2, right? Because sometimes, like up here, perfect prime example. So you're up at Glacier National Park, right? How far are you away from the really closest nearest medical center?
It'll take you an hour
it's
or
an hour
and a half.
And so you would actually likely go through 2 EpiPen injections if you were having a serious anaphylactic reaction by the time you got there.
It's not something to mess with.
It's not something to mess with, no.
So we talked about like the skin, so the hive reaction.
Yeah.
What's called angioedema, which is the facial swelling.
Right. Which you can also get from medications, right? There's a lot of medications that cause
allergies are
huge.
Way more common than when I think it's let on.
Yeah, I know.
And could be an adverse reaction.
There's a lot of common medications like lisinopril that can cause that weird angioedema that until you've seen it once, because I've seen it in the clinic, and it's like, this is not a good...
Angioedema means swelling, so that's it,
which then blocks airways,
yes.
right? So swelling, when you have a limited space for an airway, not a great combination.
And there's this thing, quick sidetrack, that hereditary angioedema where they're just sort of genetically inclined to have these type of reactions, but that's a whole separate thing.
Right.
So a lot of when you think of also the environmental allergies, so your sort of seasonal allergies, environmental
what we have
allergies.
Now?
Oh my God. Yeah. So right now we're hitting the cottonwood where it looks like it's snowing, and it's the cottonwood
and the pollen.
And the pollen, especially from the I shouldn't say tamaracks because that's not technically true, but the pine trees out here.
I was going to say our yard is just yellow.
Yeah, yep, and it's sticky and whatever, and so even people without allergies, like the load is so high. I think there's some reaction that goes on. Your eyes are stinging and people are congested.
My youngest has decided he's allergic to summer. Because it's it's the pollen, but but it's like this time of year, and
people with asthma can be taking a hit because these things can trigger asthma attacks, and asthma is tied in with these IgE mediated allergies.
Really fast, when we were talking about skin, did we talk about eczema yet?
So no, not yet, and it's interesting because that is a mixed IgE, non-IgE mediated, and we actually have a separate. So we'll talk about that in a second.
I was just seeing it up in our earlier notes, and I just was going to make sure we defined eczema, but we'll do that when we get down towards the bottom.
So I don't know if we want to talk about any of the testing for the IgE mediated allergies real quick.
I think we should, just so people know what options there are.
Yeah,
kind of, and they're not perfect, right? Because we do know that, and so it's not like you're guaranteed you do a test and this is definitely 100% your end all be all diagnosis, but it's definitely a good start.
And as far as I understand it, the quote unquote gold standard is still the skin prick testing.
Still, yep, or AKA scratch testing, skin prick testing.
Where they take a little bit of this, it's like basically a solution with that allergen in it, right? And people think like they're jabbing your back with a huge needle,
but they're just a little scratch.
Yeah, just a little hook thing that scratches your back.
Yeah, you lay there. Yeah, I did all that. You get 80, right? Little tiny.
They make a grid on your back.
Yeah, for real.
And then they look for welts.
And then you actually just have to hang out, and you can't itch, and so you have to
because
do whatever.
If you have reactions, it's going to itch.
And I was a mess.
And you can't be on Benadryl or anything like that when you do it. You have to be off all
antihistamines, steroids. Yep.
And then they see how big they call it a wheel. How big is that wheel? Not wheels on the bus, but WHEAL.
Yeah, and then they measure it.
Which is a welt, and they measure it. And then if it's above a certain diameter, then that sort of classifies you as like what stage, like 1, 2, 3, 4, something like that.
Right.
And so that's actually more the gold standard, even though their blood testing has some utility. I think from the allergist standpoint, the skin prick or whatever test is so if you came back positive on a blood test and they have this thing called the RAS test or the immunocap, which is the IgE testing for food allergens, and they'll oftentimes do panels.
Right.
But they'll often follow that up with skin prick testing.
Right. And, I do a lot of IgE testing, blood testing to start because it's something we can obtain, right? It's something we can get and then follow up by seeing an allergist and doing skin prick testing if needed.
So say if all that stuff is negative, that means like you don't have an IgE mediated food allergy, but you could very well have some other type of non-IgE mediated thing, which we'll talk about in a second, the whole category of those.
Yeah, so that's just that one piece.
You're not going to anaphylax to this.
Right. You probably don't need although, that's the funny part, right? You probably don't need an EpiPen, but then we have some mast cell folks that do have EpiPens and need to carry them because of that inappropriate mast cell reaction. Yeah. So even though they don't test positive on an IgE test. So that's where I'm like,
that's a good point.
Well, it's always like, okay, there's what, right? I just
said
it,
but
no always and no never, right? We can't say always and never in medicine. Yeah. And the word normal doesn't exist.
But we like to.
We want to. we want it black and white, but the world is gray.
But it ain't. Yeah. So, so what are the odds that your kid is going to outgrow these allergies?
Yeah, that's a good point because a lot of kids do outgrow these allergies, especially when they're young, right? So when it's diagnosed when they're very, very young, like less than 1, even less than 2.
Yep.
They have a chance by the time they're in the teenage years that they're not going to be dealing with these food allergies.
Yeah. So milk, egg, and wheat are at least 50%, I think, can outgrow those allergies.
Right.
Although I've also seen this go underground where they quote unquote, outgrew the allergy to milk, like the IgE mediated, whatever. Okay. And then all of a sudden they come back with EOE, eosinophilic esophagitis, which is often a different type of immune reaction. So it's almost like it went underground and the different immune system decided a different way to react to it.
Right.
So you don't wait for the shoe to drop, but just be aware that sometimes things can kind of morph over time and go underground. So, but as far as like the classic allergy, milk, egg, and wheat are common. Peanut and tree nut, you can, and there's those immunotherapies we talked about. We're not going to get too far into, and that can help some people kind of develop what's called the immune tolerance to that. So that's 10 to 20%. And then fish and shellfish and the seed allergies, unfortunately, that's often a lifelong deal.
Those ones you just get to keep.
Yeah.
Yeah.
Again, I don't know what sort of progress they've made with the immunotherapies for those things specifically. I haven't gone that nerdy down that rabbit hole.
I haven't either. And, a lot of times we talk to patients, right? And so you kind of have an idea of what patients have tried and what they've done. And I don't know that I've had any that have done immunotherapy with fish allergies. I think they just don't eat it.
Yeah, which is a bummer.
Yeah, for sure.
Which technically you should still be able to take a purified cod liver oil because it doesn't have any of the protein, which is what you react to. Just like technically somebody with peanut allergy, if it's a super refined peanut oil, you technically should be able to tolerate that because it has all the protein removed, but you don't try that at home.
Yeah,
and you talk to the allergist first.
Yeah, you do that with your allergist. Don't listen to don't follow her.
Yeah. All right, so you mentioned eczema. Let's talk about eczema.
Yeah, and kind of what eczema is, right? So I think a lot of people have heard of eczema, right? And so they've probably all seen eczema, but not everybody always understands, what it is on your body. A lot of times we diagnose it as a kiddo, but sometimes we don't catch it until you're an adult, or it doesn't really present until
flares
you're an
up,
adult.
goes down,
and because there is, like you mentioned earlier, there is that immunologic piece to it. And so I know as kids, there's that triad, right, where we can see that eczema, allergies, and asthma kind of go together.
Which is funny because it's still, I think, under-recognized because, from a dermatologic perspective, it's just like, oh, here's eczema, and they're focusing on the skin barrier, which is important. You need to heal that skin barrier with all the lotions and the soaks, and you soak them in the tub, and then you lather them up. But your skin
is your largest organ, and so it's your first sign of inflammation.
And it's a huge immune organ.
That's what I'm saying.
Yeah. And so, and it's known, this is written directly in the medical literature, 40% of these, especially of kids with eczema, have diagnosable food allergies.
Right.
So there's that link, and is it, causative versus association? You could get into that on the side, but
I don't think 40% know that they have a food issue. Is my thought. I really don't.
And that's just the ones with diagnosable IgE mediated ones, 40%. And then what about the ones with food sensitivities, which I think is another big chunk of those. And don't get me wrong, there are non-food related eczema things, which could be, you're reacting to a detergent or reacting to something else, or dust mites is a big one. So all those type of things.
Nickel.
So not all eczema is food related, but a lot of it is.
Right. Exactly.
And there's the whole fact with like skin nutrients, right? Like if you're not eating to have healthy skin, then you are you're predisposed. So what are your favorite skin nutrients?
Right. So like deficiency wise, like what we're looking for?
What do you make sure you need to get enough of?
Yeah. Well, and this kind of goes back to when we start looking at acne too, right?
Totally.
So zinc, vitamin A, vitamin C, your omegas. Vitamin
which is a
D.
huge deficiency, omega-3s.
Oh, huge. And then vitamin D, especially when you're in these northern latitudes. We know that really it's like that sun belt down at the very southern edge of the United States is about the only area that gets enough natural vitamin D. Our probiotics, prebiotics, right? Which again, you can attribute back to diet. So there's a whole, and I use all of those when I'm dealing with acne.
Too. trying to heal the skin. And so I think that should be always part of it. Somebody has eczema, just I sort of take it back. It's just illogical, Dr. Spock, to think that you could have healthy skin with having nutritional deficiencies, with one of the main roles of that nutrient, like vitamin A, being to create a healthy skin barrier. So always address these nutrients. And we can test for a lot of these.
Right. Yeah, we can. A lot of, some of them are a little harder, which we've talked about. And so you can go back to one of our previous podcasts when we're talking about like,
testing for nutrient deficiencies.
Exactly. But still, again, it's one of those things that's easier to address. It really is. Like this one doesn't have to be.
No. And another interesting thing that I've just really started to read more about lately are, with onset of like genetics and epigenetics, and they're looking at these different, what we call polymorphisms, just meaning like you have these certain different genes and how and something called nutrigenomics, which is looking at how your genetics affect like your nutrient, and which I think is fascinating.
It is fascinating. So I'm going to throw this out too, because I've just been doing a real deep dive on mast cell recently, right?
Okay.
And so with mast cell activation, and I'm sure it has to do with the actual mast cells in there, but not absorbing proteins as well. And again, how would you know? You know, because you're like, oh, I'm eating all of this stuff. Why do I have?
If you have gut edema, like if you have kind of the mast cells make your kind of guts kind of swollen, and then it doesn't absorb stuff, and probably way more than just protein. But
well, it's way more than just protein. But that was just a big one because it's like, oh, wait a second, that's why we have this increased need for protein when you have those.
But they've also found that so most people get their vitamin A, so beta carotene, which everybody's heard of. It's like in all your orange and actually your green leafies as well. It's like there's a nutrient called beta carotene. It's an antioxidant, definitely an important nutrient. It's essentially two vitamin A molecules kind of stuck together.
Right.
And there's an enzyme in your body that basically breaks that apart and creates vitamin A, something called retinol or retinoic acid, which is the active form of vitamin A in the body, which is what your body actually uses. It doesn't actually use the beta carotene directly, but I don't know what the percentages are overall off the top of my head, but a significant proportion of people are inefficient. They can still do it. They're just not as efficient at breaking those beta carotenes apart to make the vitamin A. And so in essence, they could look on paper like, oh yeah, you're getting enough. Although a lot of people are not getting enough of the carotenoids and the beta carotene in their diet because they don't eat vegetables. But even if they were getting that, but they weren't really able to make that active vitamin A enough, and then it can lead to all sorts of things that are essentially like a low-grade vitamin A deficiency.
Right.
And so, I always tell people when you're looking for a multivitamin, look for one that has some but not excessive amount of preformed vitamin A.
Right.
But also,
So what does that look like in a multivitamin? Like when they're looking at the label, what's it going to say?
So if it'll say vitamin A, but if you look next to it, it says as beta carotene, that's probably 80% of the multivitamins.
Mm-hmm.
But if you're looking on it and it says as retinoic acid, or it could be the retinaldehyde, I think it's just usually retinoic acid.
Right.
Or a retinoic acid equivalent as vitamin A.
I was going to say, it's usually like this tiny little, they abbreviated, like it might just be retina. Like honestly, sometimes it's just teeny
retinol,
tiny.
yeah.
Retinol.
Yep. And so, but if it has that means it has some of the preformed vitamin A in there, and usually it's not typically going to be over like 2,000 to 3,000 units or something like that, because high vitamin A amounts, which is why they always get afraid of putting in a multivitamin, I think, is because it can be toxic. But if you're taking like 50 to 100,000 units, then it can be toxic. If you're taking, for an older kid, 5 to 10,000, and interestingly enough, what's one of the more common treatments for acne?
Vitamin A?
No.
Wait, what do you mean?
Like the actual prescription.
Like tretinoin?
Yeah, I mean, it's basically a vitamin A derivative.
Oh, yeah. Okay, yeah.
So, but
the cream?
Yeah.
Yeah, totally. And it's over the counter now.
Oh, is it?
I think.
Huh.
Okay, I'm not going to totally go crazy there, but I kind of think it went OTC like a year or two ago.
Yeah, interesting. But there's been some actual studies where doing supplemental safe dose vitamin A actually improves acne.
Well, we make
I guess
sure
that's not a shocker to me.
I was going to say, we make sure we address that one.
But they don't tell you that, No. So.
Well, because it's a vitamin.
Yeah. Okay. All right. So moving on to one of my favorite topics.
Yes.
EOE.
So, EOE, yes. Why don't you define EOE for us? Because I think everyone has kind of one, people don't know what EOE is. Two, if they do know what it is, they maybe only kind of know what it is unless they are directly impacted.
Yeah. So EOE falls under one of these categories as a mixed IgE, non-IgE mediated. I think it's possibly more IgE mediated immune reaction to foods.
Right.
And it's so I guess sort of backing up, interestingly, it's a new disease. Like literally before the 1990s, maybe in like the mid 1980s, it didn't exist.
And do we think it didn't exist at all?
We actually think it didn't exist. They went back and looked at biopsies that they had stored frozen for years from like the old school scopes from back in the 70s and whatnot, and didn't find it. So it is new.
Okay.
So that's a rabbit hole. Again, going back to our earlier conversation, what has changed, in the 80s and 90s in our food supply, in our environment, and there's a number of things, but whatever you kind of, pick your rabbit hole, led to this immune dysregulation and disruption. We think a huge part of this is just disruption of that protective layer of your gut, of your esophagus. And so EOE stands for eosinophilic esophagitis, which means in your esophagus, your food tube that goes from your mouth to your stomach, you have inflammation. So that's esophagitis. And you get esophagitis from like bad reflux. You can get esophagitis if you have yeast infection in there. That's candida esophagitis. And this is eosinophilic esophagitis, which is these immune cells, these allergic cells get lined up in your esophagus. They cause inflammation. They cause swelling. Given long enough, they can actually cause strictures where it's like a narrowing of the esophagus.
Right. And then you can have choking and have food stuck, right?
So this is a silent epidemic. Yeah. Like even in my career, and I trained at one of the top EOE places in the country at Children's Hospital, Colorado. They were one of the first early big research centers, and just watching the evolution from when I started training there, and even like when I was sub-eyeing there, which is like where you test drive your fellowship stuff when you're in residency.
Right.
So this would have been like in the 2000. I don't know, like 2006 through 2009, and then I started my GI training in 2009. Even since then, I've just watched like the incidence of this go up and up. And there I was kind of skewed because we were a huge referral center for like the western half of the U.S., you know. So we're seeing all these cases kind of come in.
And you're seeing the kids that have been worked up, didn't find another cause, or found this thing and they're like,
what is it? Yeah.
Right?
Yep.
And then so you get all of the really tough cases.
And now, I mean, practicing in Montana since 2012, it just, what I'm reading is supposedly the national averages for this. I'm like, we're blowing that out of the water. And I'm interested to see what the new what they call incidence and prevalence of this disease is, because I know I also practice. I do some locums work out in Seattle, and same thing. It's like an EOE tidal wave.
Well, I sure feel like we're seeing a lot more.
Every time I scope, I diagnose a new case of EOE.
Wild.
And so So when you get this inflammation in your esophagus, essentially how it can present as early as like the late infancy. Like I've had kids, like the youngest I've ever diagnosed, I think it was like 9 or 10 months old. So in that age, it's like vomiting and then solid food refusal, where the kid, as they're kind of weaning on, so should be weaning on solid foods.
Right.
They will not eat anything that has any sort of texture that takes effort to swallow. They'll only do liquids and maybe purees, and that's it. And then I'll get these kids, they're 2 years old, they're still not eating solid food, and then they're like, you're like, yeah, they used to puke a lot when they were younger, and then we end up scoping them, and bam, like full-blown EOE.
Yeah, because kiddos naturally will avoid things.
Yeah, they're not stupid. If it hurts, I ain't doing it. If it hurts to poop, I'm not doing it. Yeah. So, I
mean, really, and that, we notice that, and then it's as we get older, sometimes we like force through things. So, but kiddos they naturally avoid things.
So and then the other sort of big thing is like, basically it's the teen who's probably had symptoms for a year, hasn't told anybody, and shows up in the ER with a piece of steak or chicken stuck in their esophagus, and I get called in the middle of the night to go pluck it out of there.
But
and
they
then
also maybe don't really know. Because, when you're a teen, you don't really know. You're just like, oh, this is what life is.
Yeah.
You're kind of learning.
It should hurt to everybody. It's painful to swallow, or I have to slam, water or juice or something with every meal to force the food down.
70 times. Yeah.
So the other kind of hallmark signs are, a lot of choking and gagging, recurrent vomiting, chest pain that's not cardiac related, sort of reflux symptoms that don't get better with reflux meds. In that younger kid, that solid food refusal, super slow eaters, super picky eaters. I mean, all that should be on the radar. Like, could this be EOE?
Right.
And it's funny because we deal a lot with our, we call feeding therapists, but usually typically speech SLP, speech language pathologists who do feeding, and sometimes OT, occupational therapy, that do feeding. Yeah. And because we have a great relationship with them, because there's a huge need, because after you diagnose them and treat them, you have to kind of wean them back onto a regular diet.
Which is mental too.
It's hugely mental. So you develop these food aversions, something called ARFID, avoidant restrictive food intake disorder, which we're starting to recognize more. And ARFID and EOE are like peas in a pod.
Right. And you're like,
for good reason. You can kind of see. And sometimes I look and I'm scoping, I'm like, oh, that hurts me just looking at it, because it's all inflamed. And, treatment usually can be involved with, surprisingly, swallowed asthma medicines that you swallow instead of inhale. But asthma and EOE are kind of like, you can also travel in circles. That food allergy, asthma, eczema, they're all traveling in the same, and EOE all travel in the same circles. So those are kind of the main presentations. And most of the time, the blood tests and the skin prick tests for quote unquote food allergies, are negative, and you can't use those to tell. Unfortunately, God, I wish we could tell which foods they're reacting to.
Right.
There's no good testing right now that exists to tell you exactly what foods are reacting to. We have to go we know that the big four are wheat, dairy, soy, and eggs. But then there's also some, nuts, fish, corn can be sort of not as common, but still common.
So are you doing full food eliminations, like a food elimination diet, and then a slow reintroduction?
Because dairy, cow's milk is usually involved, and I'd probably say at least 70% of the cases. So sort of common things being common, I usually try a dairy elimination if they're willing to. Sometimes it's just like it's such a key part of their diet, they won't do it, can't do it. And then we have different meds. We do like swallowed Flovent or budesonide, or there's a new what's called a biologic medication, an injectable that just got approved for use in kids within the last year or two, called Dupixent. And that basically blocks the eosinophils at their source. So it just like knocks that all down. And so for the kids that can't follow the diet, or you're removing like a zillion foods and they still have the EOE, and you're like, you just can't, it becomes so prohibitive that that kid's not going to be able to gain weight or anything, then that Dupixent can be a godsend, So I'm glad we have it, but there are times when I just take the dairy out of their diet and the EOE goes away. And then I will also work on healing the gut, like kind of the 5R protocol, work on the microbiome, work on, removing the things out of the diet that are damaging that mucosa.
And then rehealing it.
And then rehealing it.
We do a lot of the 5R here.
Totally.
Because we use it for almost everything. I mean, honestly, like I use the 5R protocol with like multiple diagnoses, because, it starts in the gut.
All disease starts in the gut.
Yep. And the gut-brain the superhighway. I mean, just everything.
Totally.
So, I have patients that come in with ADHD, things like that, and we're starting in the gut.
Yep.
And so they're like, why are we working on my gut? Well, let me tell you.
Yeah.
Because very much related. So so in a nutshell, EOE new since the late 90s, right?
I'd say late 80s.
Late 80s,
yeah.
okay, late 80s. And obviously there's a rabbit hole when we start talking about why, so we won't go there. Multiple food triggers likely, very difficult to test. Pretty much diagnosed on a scope
Endoscopy,
after, so an endoscopy or a scope down your throat after symptoms are noticed.
Yep.
But often symptoms it takes a while.
But if you notice this in your child, then they're having any one of these, bring it up to their provider.
Yes.
Consider referral to a pediatric GI because again,
or call us.
And if you're an adult and having some of these things, and it's like again, this is way underdiagnosed, and we're diagnosing multiple generations where grandparent, parent, kid all have EOE, and we diagnose the kid, and all of a sudden,
mom or dad is like,
mom or dad
ooh.
start looking at each other, and then they look at grandpa, and they're all like, oh, everybody gets food stuck in their throat. And then boom, 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 you diagnose and treat and everybody can eat steak again. It's all good.
There you go.
But let your provider know, get a referral to a GI. Not all adult GIs are as up to speed on EOE as I think the pediatric providers, just because but it's kind of bled over. It used to be it was just mostly kids to begin with, but now those kids are now adults, and I think it's just increasing everywhere.
Late 80s, right? I mean, that's my generation and on, right? And we're all functioning adults.
Well, I'm sometimes functioning.
Okay.
All right, so now we'll go on to some non-IgE mediated other reactions very quickly.
Yeah.
And then we'll talk about the kind of non-immune mediated stuff to kind of round it out. So the non-IgE mediated stuff that is still an immune reaction. One is called FPIES, which stands for Food Protein Induced Enterocolitis Syndrome. There's a lot of misunderstanding about this. So this is a kid disease. I don't really believe that there's such a thing as chronic FPIES because that would be a different beast. So what this is an acute reaction that happens it's usually infants or maybe really young toddlers when they're exposed to a food for the first couple times, and then their body have this delayed reaction where like an hour, 2 hours, 3 hours later, all of a sudden the kid starts projectile vomiting, and they look like death, like they look like they're going going into shock
because they get sweaty and diaphoretic, pale,
limp,
Those are scary.
And it's not just like throw up. I mean, it is like exorcist style projectile vomiting. Yeah. And usually like the first time it happens, maybe it's not that violent, and then the next time it's like, holy, usually end up in the ER.
Right.
And then the ER is like, they run all the tests, like, it's not, they're not, and you do the allergy testing done, it's all negative. So this is what's called a T-cell mediated. So definitely a different thing than the whole antibody IgE mediated. And the good thing is like almost all the kids outgrow it by the time they're like 4, maybe 5. And interestingly, it's a lot of milk and soy are really common triggers of that, and when they're getting introduced to that. But also we had our older daughter, sweet potato, which is not uncommon. Rice and oats are also common. So you think about, you're introducing rice cereal, oat cereal to a baby.
Away.
Yep, right away. And so this thing can happen when they're 6 months, 7 months, 8th month. Like that second or third time they get introduced to that food, and their immune system's like, freaks out and boom. So just be aware of that. Again, that you just avoid that food, and then when they're a little bit older, it helps to get plugged in with a GI or an allergist, and then there's food reintroduction. And typically this isn't life-threatening, even though it looks like it. But kids can go into almost shock, like get low blood pressure, need IV fluids. So it's a serious thing, but it's not like their airway's not going to close up. It's different than anaphylaxis.
Right. Okay.
And then really quickly, what's called infant proctocolitis, or the baby blood in the poop type of thing, which is often commonly a reaction to like a milk protein, cow's milk coming through mom's breast milk, or milk containing formula.
Those are the common ones that I've seen in clinic are from that.
And a lot of these kids unfortunately get allergy testing done, which first of all, until you're over a year old, you shouldn't really do allergy testing, because like your immune system is mom's immune system at that point, and then your immune system is developing. But
they respond really well to elimination. Like if you take away the trigger. And
typically outgrow it, although this is another one. Do they always outgrow it? I don't know. But it's usually not. It can be severe, though. I will say that. Like a lot of times, just a little bit of blood in the stool, and mom does elimination, and I was like, do not switch off of breastfeeding unless the baby's in serious danger.
Right.
I mean, work with somebody on that, but there's so many benefits to breast milk if they can eliminate the stuff, and even if there's ongoing just a little bit of blood in there,
right.
Then a lot of times we'll monitor it and we'll check the iron levels in the baby to make sure. But there's so many other benefits of the breast milk. I really try to not take them off that.
Away. Yeah, gotcha.
Celiac will probably be a whole separate podcast in and of itself.
I was going to say, I know that one. I don't think we can adequately cover in a minute or 2 minutes. So maybe we just, start by saying we're going to cover it, and we're going to totally dive into that deeply.
Because there are multiple. We could do a whole one on just celiac or wheat and gluten reactions. Yes.
Right.
But celiac, so just so you know, obviously that is it's sort of a food allergy because it's definitely a major food reaction. It is immune mediated, but it's not IgE mediated. So the blood testing, the standard allergy blood testing doesn't work.
Yeah.
Skin prick testing doesn't work.
Right.
You need to test it with something called a TTG IgA or tissue transglutaminase IgA or a deamidated gliadin peptide.
Right.
So these are antibodies that sort of get built up when there's that gluten reaction going on in the gut. And they're pretty good. They're 92 to 95% accurate for at least, screening diagnoses. And then you may or may not need an endoscopy to confirm the diagnosis and assess how much damage there is. Because celiac is a gluten reaction, immune reaction in the body that actually causes physical damage to the upper part of the intestine called the duodenum. And you can measure this on endoscopy. And over time, if it's untreated, it can cause a host of different symptoms. Everything
malabsorption, vitamin deficiencies, and then again, where it's autoimmune piece,
opens the door to other autoimmune disease.
I was just saying, we talked about this a lot previously. You have one autoimmune disease, where's the other?
Yeah.
Right. And is it just not diagnosed yet? Is it not identified yet? what's the sitch there? Yeah, for sure.
So if anybody. And this is coming straight out of the major gastroenterology associations. If there's any undiagnosed chronic GI symptoms, automatically
do testing
by law. But do testing.
Yeah.
And I don't care how old you are.
Yeah.
Because this is not just a kid disease. Celiac disease, first of all, it's now thought to be between 1 in 75 and 1 in 100 people in the U.S. have celiac. So that's a big population of people.
Number.
At least half of them are probably undiagnosed.
Right.
Because they have IBS that have never gotten worked up, or they have other symptoms like chronic migraines or skin stuff or chronic fatigue or unexplained anemia. Yeah. All those conditions, anything that's
vitamin
unexplained.
D deficiency.
Yeah.
Right.
Actually, right now, Italy is screening every single person in their population. Mass screening.
You were saying that, and they do so much pasta.
Yeah. Well, so do we.
Well,
Olive Garden.
I was gonna say we don't do just pasta. We also do bread and everything.
Yep.
Yeah. Okay. So let's the rest of celiac though
we'll go into. Yep. Exactly. Yeah. And then there's things that again we won't go into too much today, but that are sort of potentially or partially immune mediated. So even infant reflux and colic a lot of times are a reaction to the formula or something in mom's breast milk or something like that there's an immune reaction there. Again, not a classic allergy, probably one of these non-IgE mediated type of things.
Right.
And there is an immune component, an inflammation component, likely a food reaction component. Again, we'll probably have a separate podcast on this, but just know that yes, reflux and colic very much, and this is written about in the medical literature. This is not like a fringe theory or just a functional medicine thing, but it is under-recognized. And a lot of times you correct the microbiome and change up the formula or do some dietary elimination in mom's diet, and these things get way, way better.
Right.
Irritable bowel.
Well, and again, so it's everything you just said, but also adding in the lifestyle components, right? So the stress, the exercise or lack thereof, or excessive, because it can be both. Those things can impact that immunologic response as well.
Not so much for the baby, but
not for the baby. Well, but for mom, for breastfeeding, right? Yeah. And so if we're breastfeeding and we're their diet 100%, I mean, those things matter. As when breastfeeding mom back in the day, it's been a hot minute, but there's just so many pieces that go into that, and moms can tell you, oh yeah, I don't make as much milk when this happens, or
the stress thing. Yep. Absolutely. Yep. And then it becomes a vicious cycle.
So IBS, I just think there's so many components that are attributed when we start talking about IBS. And then food sensitivities.
Overall, which is a huge thing overall.
Right.
And you know, I said that one of the key examples of this is non-celiac gluten sensitivity, which again is defined in the medical literature. They still have these, you know, typically GI, quote unquote, irritable bowel syndrome reactions.
Yeah.
But the celiac testing is negative.
And there's I just read about this, but now I can't remember what the study was, but they're working on a whole new lab to identify this. So that's like right now in the testing phase and it's been very successful thus far.
Yeah. And again, there's specific, like, gluten, different type of gluten antibodies that they will target. And then there's some other ones that are more, you know, actually are sort of like surrogate markers for leaky gut and some other really subtle inflammatory markers that are sort of used to quote unquote diagnose IBS, although people with IBS can usually tell you what they got.
Right.
So that's a whole nother rabbit hole. Yeah. And then briefly we'll go over the non-immune mediated food reactions, the ones that are like you're reacting to something in the food, but it's not IgE mediated, it's not T cell mediated, it's not like your immune system really doesn't have much to do with it.
Right. Like we don't think it's not going to show up on IgG, but there is something that you are consuming that's causing a reaction.
Yeah.
Exactly. And that can look a lot of different ways.
Yeah.
Like
what are the big ones?
Well, we talked about histamine. I think we kind of mentioned that at the very beginning.
Histamine intolerance. Yep.
Histamine intolerance is huge, and it's always one of the things that I have people kind of peek at because you have foods that are high histamine containing foods, and then you have foods that are high histamine releasing foods, and they can make a big difference.
Yeah.
So bananas, right? You know, if you can eat a really like green banana, that's actually really low histamine, but a really ripe, almost brown banana is super high histamine. A strawberry off the vine, low histamine. Strawberry that's been sitting there for 2 weeks is high. So like it can be that simple. I mean, simple in quotes, right? Yeah. But also like your FODMAP type stuff. Yep. Right?
Yeah, the FODMAP food. So
tell us what the FOD, because I always forget how to acronym.
I think it's fructooligosaccharides, disaccharides, monosaccharides, and polyols.
Okay, because I'm like, I always forget.
So polyols are like your sugar alcohols. Like when you look at all these keto and sugar-free things with erythritol, maltitol, and those can be a gut bomb disaster.
People react to those all the time, and you just don't know it.
And it can be a quantity thing. Like a little is okay, but then you're like, go to town on whatever that supposed sugar-free thing is, and then you're just like, bloated and miserable, and just because you're not absorbing it. And when you don't digest those sugars, guess who has a party with them?
Right, your
gut microbiome.
Yep, your gut, because your gut is going to eat. So when you're eating, you're feeding that microbiome. So you make choices, but also like the other additives. Yeah. Right. So coloring, other flavors, that quote unquote natural flavors.
Yeah, which you don't know what the heck that is.
What is? Yeah. So, but all of those things,
it doesn't actually mean anything by law, unfortunately.
Right. But so all of that though, how, those.
They can absolutely cause reactions, but it's more of like, it could be a chemical, like irritant type of reaction. It could be, it's malabsorption type of issue. So lactose intolerance is the classic one. Everybody knows actually technically 70% of the world apparently is to some degree lactose intolerance. Right. And I think it is important to differentiate lactose intolerance from milk protein allergy because they get sort of conflated all the time. Right. And so milk protein allergy, which can be IgE mediated or non-IgE mediated, that one, even if you're doing lactose free or taking lactate pills or whatever to break down the lactose, which is the milk sugar, the milk protein is what's actually causing the reaction in those folks. Yeah. Versus lactose is, if you have, you just can't break down that milk sugar and, can cause a lot of bloating and diarrhea and cramping and things like that. And so that, either you go the lactose-free version or you take a lactate, the enzyme that breaks that down.
It's like a little pill.
Yep, little pill, and then they can tolerate some of these things. Again, extremely common. And I guess the other quick thing is you have primary lactose intolerance, which means genetically, we're designed to digest lactose when we're babies, and then by the time we're like 8 to 10 years old, a good number of people, your body stops producing that enzyme because they're like, you don't need milk anymore. Right. And then it can be just GI distress when you have a high amount of lactose, and then there's secondary lactose intolerance, which means that something has already irritated your gut, like SIBO, small intestinal bacterial overgrowth, or celiac,
candida,
or other things. Anything that kind of irritates your gut. I gave it the example like, okay, you just had food poisoning or something like that, and you're just getting over it. Are you going to chug a couple glasses of milk? That's not going to end well, because you're probably going to be lactose intolerant for a bit. And you can probably build that back up, but you just damage the heck out of your GI tract.
Yep. So you got to wait. You got to hang on. You got to let it heal. Yeah.
And fructose intolerance is actually exceedingly common, which is we think of it usually in the realm of toddlers' diarrhea, where you just take the juice out of their diet, cut down the amount of fruit, and their poops normalize. Right. But also adults too. Like there's a glass ceiling where it's like, I can have a certain amount of fruit, but if I have a big gulp with all that high fructose corn syrup in there, boom, GI distress, because you've maxed out the amount of fructose you can absorb, and then all that extra sugar goes through and it pulls water into your GI tract, and those gut bacteria start to ferment it and have all sorts of interesting reactions.
And then you have bloating, you have diarrhea, you have all kinds of stuff.
Yep.
Uncomfortableness.
Yeah. So that, I think, is it in a nutshell. We went a little bit past our usual thing, but I think we covered a lot of important things. So we talked about the different testing methods. We talked about...
Shocking, we got chatty.
Yeah, I know. We talked about elimination diets, which is always the gold standard, but I'd say we do a lot of it here.
We do a ton here. Yeah. And we'll talk, I think maybe at one of these podcasts, we just talk about the elimination diet, because there's also multiple types.
Yes.
And so, I think we all do.
And it does help to have guidance.
It helps to have guidance because they're hard.
Yes.
They're stressful. And then when you're like, how many times are we going to add stress in? But like stress increases all of your, the cortisol and everything. And then it makes all of your reactions larger.
Yep, absolutely.
And so having somebody to kind of walk through it with you is critical. Mm-hmm. Yeah.
Yeah, we talked about the 5R, kind of healing the gut and the importance of that. Again, something we do all the time here at Functional Medicine Associates, the gut microbiome, and the importance of that, and trying to either prevent or kind of backtrack out of some food reactions.
Right.
And then those key nutrients that we talked about, things like your vitamin A and
your omegas.
And omegas.
Vitamin D.
Vitamin D, super important.
For sure.
So that is the sort of down and dirty immune 101 when it comes to foods.
Right.
So hopefully this was helpful. And again, if there's a major reaction going on, talk to your provider about it.
Sure.
Come see us here at Functional Medicine Associates. Again,
visit with your allergist.
We both deal with this all the time. You deal with a ton of the mast cell stuff. I deal with that as well, and gastroenterology related food issues and things like that.
Totally.
So we both are well steeped in the food reaction department.
Right. Yeah, for sure. We do want to thank a couple people. Triple Divide Creative as our producer, as always. I also want to throw a shout out to my mom, Colleen Champlin, for making our really awesome new wall hanging. Yeah. So super appreciative of that. I think,
Yeah, and so, find us on our socials.
Yes, all of the major platforms.
So we're at Functional Med Associates.
Yeah, we're on Facebook, we're on Instagram, our website, functionalmedassociates.com. Give us a call.
Please share this with, if you have friends who have food reactions, or you kind of are somebody, when we talk about this, somebody pops into your mind, please send them this podcast, share it, it, leave us comments, it'll help more people, because I think a lot of people need to hear this information.
Agreed, 100%. All right, thank you.
Yeah, thanks for listening.
Thanks, as always. We'll see you in 2 weeks.
Okay,
bye.
Bye.